enhancements in healthcare information technology systems, customizing vendor-supplied clinical decision support for a high-risk patient population. Presented by Cynthia Joseph. Authors, Rachi T. Wary, Demetra S. Sopepas, Jacqueline T. Powell, and Spencer T. Martin. Healthcare organizations continue to adopt information technologies with clinical decision support (CDS) to prevent potential medication-related adverse drug events. Individuals who are unfamiliar with certain high-risk patient populations are at an increased risk of unknowingly causing medication errors. The need for institution-specific customization of vendor-provided CDS is paramount to ensure avoidance of medication errors. Individualized care will become more important as patient populations and institutions become more specialized. Medication errors and adverse drug events lead to significant morbidity, mortality, and increased cost for hospitalized patients. Healthcare organizations increasingly use information technologies with clinical decision support to prevent potential medication-related adverse drug events. Solid organ transplant recipients are at particularly high risk for medication errors resulting from drug-drug interactions owing to complex medication regimens with narrow therapeutic indexes. The care of transplant recipients is further complicated among individuals infected with HIV who require treatment with highly active antiretroviral therapy. A 58-year-old man, diagnosed with HIV, presented for orthotopic heart transplant, secondary to ischemic cardiomyopathy. At the time of transplant, the patient was maintained on a stable HRT regimen. 3 months before transplantation, the patient's CD4 count and HIV viral load were within therapeutic range. Immunosuppressive therapy at the time of transplantation included intraoperative intravenous methylprednisolone followed by an oral prednisone taper, mycophenolate mifetyl twice daily, and tacrolimus for a goal whole blood draw concentration of 10 to 12 nanograms per milliliters. Sublingual tacrolimus was started on the morning of postoperative day 2 at a dose of 1 mg every 12 hours. On day 5, a tacrolimus concentration of 45 nanograms per milliliters was misinterpreted as a peak value. Therefore, an additional 1 mg of oral tacrolimus was administered. Upon appropriate identification of an elevated tacrolimus concentration on day 6, administration of tacrolimus was discontinued until day 8. At this time, the tacrolimus concentration declined, and a one-time dose of oral tacrolimus was given. On day 9, the tacrolimus concentration increased to acceptable ranges. So the patient did not receive any additional tacrolimus doses during the remainder of his inpatient stay. The presence of persistently elevated tacrolimus concentrations is especially concerning owing to significant and potentially irreversible side effects from the medication. The most severe adverse effects associated with tacrolimus are acute renal failure, infectious complications, tremors, headaches, delirium, and coma. After this patient case, workflow analysis identified that the electronic health record vendor had set the default for a DDI resulting in a moderate severity for the combination of HRT and CNI therapies. Only major severity DDs, as defined by our institution's CDS committee, were programmed to present an alert to clinicians. Therefore, no electronic alert was produced in this patient case. Identification of the clinically inappropriate vendor default severity settings prompted our institution's CDS committee and transplant pharmacy team to review and modify the standard DDI defaults for tacrolimus. The team reviewed 4,692 potential DDs related to tacrolimus, reflected in 329 drug pairs at all severities, minor, moderate, and major, and, based on literature review and clinical expertise, 82 pairs were modified. Publications exploring the impact of healthcare information technology in solid organ transplantation are scarce. A comprehensive understanding of the process of medication use is essential for implementing effective electronic error prevention strategies. The potential impact of information technologies on avoidance and reduction of medication errors through safeguards at all points of the medication use process is profound. Maintaining, customizing, and continuously evaluating all CDS systems within a vendor-supplied EHR is vital to ensure that the most applicable data are provided for patient care and safety. Computer-based clinical systems and decision support is accurately depicted in this case scenario. Computer-based clinical systems and decision support is designed to assist physicians and other health professionals with decision-making tasks, such as determining diagnosis of patient data. All parties are responsible for encouraging transparency and communication so that medical information companies can provide evidence-based decisions to modify product standards. The ongoing exchange of modifications made to clinical decision support tools will enhance the future of meaningful EHR systems for patient care.